The IKEMA study is a phase 3 randomized study in patients with relapsed myeloma, comparing carfilzomib and dexamethasone, one of the standard of care, versus carfilzomib, dexamethasone plus isatuximab. Isatuximab is a monoclonal antibody targeting CD38. So patients were enrolled when they had at least one prior line of treatment, 1 to 3 prior lines of treatment, and they received either carfilzomib and dexamethasone, KD, at the dose of 56 milligram for carfilzomib, or the same combination plus isatuximab, IV, 10 milligrams per kg weekly during the first cycle, and subsequently every 2 weeks. And the primary endpoint of the study was progression-free survival. And we have reported at EHA the pre-specified interim analysis for progression-free survival. So the patient's characteristics were well balanced in the two arms of the study. We have 10% of the patients above the age of 75, 1/4 of the patients with high-risk cytogenetics. The median number of prior lines of treatment was 2. And also 30% of the patients were refractory to lenalidomide at the time of study entry. So the primary endpoint, PFS, the median PFS in the control arm, the KD arm, was 19.1 months. So that's a good control arm. When thinking about the pivotal study for the approval of KD, the end of our study, the median PFS was 18.7 months. So definitely a good KD arm. And if you are adding isatuximab, we are improving progression-free survival with a hazard ratio of 0.53. And this is representing a 47% reduction in the risk of progression or death. So definitely a very good hazard ratio in favor of the triplet combination. This PFS benefit was observed across all subgroups of patients. And also, as a secondary endpoint, we looked at the depth of response. Overall response rate was very high in the two arms of the study, but much higher in the isatuximab arm. And we looked as well at minimal residual disease negativity, and the rate of MRD negativity was 30% by NGS, 10 to the minus 5, in the isatuximab arm versus 13% only with KD alone. Other secondary endpoints, time to next treatment was delayed, significantly delayed, with a hazard ratio of 0.56 in the isatuximab arm. And also, we looked at overall survival, but the data are not mature because of the short follow-up. The study is ongoing, and we will present overall survival data later. What about now toxicity? With the addition of isatuximab, we are not adding any significant toxicity. The discontinuation rate is identical in the two arms of the study. The fatal adverse event rates are also similar in both arms. And the infusion-related reactions with isatuximab were reported only during cycle 1 and only grade 1 or 2. So definitely the triplet combination is feasible and manageable. So to conclude, we can say that IKEMA met its primary endpoint with a significant benefit for progression-free survival, and this hazard ratio, this very good hazard ratio of 0.53, with a benefit across multiple subgroups of patients, and the safety profile is rather good, in fact, with a favorable risk-benefit for patients with relapsed myeloma. So this study potentially will be the pivotal study for the approval of KD isatuximab for relapsed myeloma.